not, we just start introducing you to our two next panelists. First, we're going to have Dr. García-Cazorla, García-Cazorla. She's joining us from Barcelona also. She's a child neurologist specialized in metabolic diseases, and she is in a lot of panels of rare diseases too. She is one of the leading doctors, or the principal investigator in the L-serine clinical trial. And she would tell us a little bit more about the function of the NMDA receptor associated with child symptoms and possible treatments. And then right after that, we're gonna hear from Natalia, Julià, who also works as a child neurologist, who also works at the Children's Hospital here in Barcelona, this Hospital Sant Joan de Déu. And she would talk about the the L-serine clinical trial, which actually carries the title of Tolerability and Efficacy of L-serine in Patients with GRIN-related Encephalopathy. So with no more delay, I'll just leave you with Dr. García-Cazorla. Thank you.
Thank you very much, Sandra, for the kind introduction and also for the invitation to participate in the meeting today. Okay. So Sandra asked me to talk about function of NMDA receptors, clinical symptoms, and treatments. So about everything, but in fact, I will try to give an overview and focusing on clinical aspects and treatments. Although I will just say a word about function of NMDA receptors. Dr. Altafaj already explained a lot of things very nicely, so I will go very quickly to those aspects that have been already mentioned. So, well, you know that neurons use neurotransmitters, and they, well, we can in fact compare the neurotransmitter when they bind to the receptor to a key that goes to a lock, binds to a lock. So in fact, NMDA receptors are glutamatergic receptors, so they use glutamate as a neurotransmitter. Here we have the molecule of glutamate, and they go to a sort of receptors that are not only NMDA receptors, but a group of receptors that can be divided into ionotropic receptors, as you can see here, the NMDA, but also AMPA or kinase receptors. Ionotropic receptors are characterized by because they can use, or ions can stimulate, ions such as magnesium or calcium or others can stimulate these receptors, and are also channels. They are, classified as channels. There are other kind of receptors. We are not going into the details, but in fact, glutamate, when this neurotransmitter binds to these receptors, a response to the postsynaptic neuron is triggered, so excitability is produced in neurons. Glutamate is the main excitatory amino acid neurotransmitter in the brain. 90% of excitatory synapses use glutamate for neuronal communication, so this is really very, very important. These NMDA receptors are critical for many functions of the brain, and in particular during development. They are involved in neuronal survival, in circuit formation, and very important in synaptic plasticity processes that are linked to learning, memory, behavioral aspects. That's why many of these children have all these cognitive functions that are affected. Neurons communicate to each other in circuits that establish between them. It is not a simplistic picture of one neuron sends a message to the other, but is an interconnection, is more complex than that. And these circuits have to have a balance between inhibitory and excitatory transmission. We already said that glutamate is the most important excitatory transmission. When glutamate is released and goes to the postsynaptic neuron, there is an action potential that can be registered. So a signal, a message that is sent. So we can say that excitatory communication mediated by glutamate is the responsible of not the noise, but if we can compare this communication to a conversation, in a conversation we are saying some words, but we are also making some silence in order to have like an harmony. We don't talk a lot all the time, or very, very high, but we just need to stop a little bit in order to understand everything. So the words are glutamate, and the silence are GABA, are ruled or are managed by GABA, which is the inhibitory neurotransmission, and this inhibition makes the neuron stop a little bit this conversation, and so the action potential is a little bit slowed down, a little bit blocked. So this is a perfect balance that is really very important during a neurodevelopment, and in almost every kind of neurodevelopmental disease there is an alteration of this balance between excitatory and inhibitory neurotransmission. So we can compare neurodevelopment to an orchestra that has to be perfectly tuned, and the silence has to be inserted into the music that multiple instruments are performing just to have a perfect harmony. If this magic organization, it doesn't work properly because some of the elements are disturbed, we can have very, very important neurodevelopmental diseases. So either in a gain of function or in a loss of function, we will have a disturbance of this equilibrium, of this balance, because after the receptor, when the glutamate binds the receptor, we have a very complex network of chemical and cellular reactions that have to be have to evolve in a very natural, in a very organized and tuned way. And this is not only a question of one cell that communicates to the other, or some groups of cells that communicate and have a conversation between them, but it's a question of a system, which is the nervous system. So there are circuitries in the brain that are glutamatergic circuitries that use these glutamate and also NMDA receptors. And these are these circuitries that are in the mature brain, in the brain of an adult, or even in a grown-up child. So we have a cortical circuits that go from the cortex here to the brainstem, which is here, but also to the cortex, to the striatum, which are the basal ganglia that are responsible of movements. We have other cortical circuits, so a conversation between the cortex. So there are several circuits of glutamate and NMDA receptors, but these NMDA receptors are not distributed in the same way during all development. It has been already mentioned that for sure that there is a very important expression of these NMDA receptors prenatally in the brain, and then their expression decreases over time, leading to the localization of certain brain regions, as we can see here. So there are few works trying to show in humans, in animal models. There are several reports, but in humans there are a few works that try to explain this evolution of these different subunits, and this is one of them. So at the beginning they go, as Dr. Artafat just mentioned, more or less in parallel, but then there is low, the green to be go rather low in their expression, and the opposite way, green to A, go a little bit higher in their expression as time goes by, and in different brain areas. This is what happens during development. It is also an interesting article about a human fetal cerebral cortex. You know that cortex is the surface of the brain. If we can cut the brain like that, this is the cortex, the surface, and then we have the white matter here. So This work shows that different subunits of the NMDA receptors express in a different manner at different times of pregnancy. So NR2A has a greater expression as 22 weeks compared to 17 weeks of gestation, and it's the opposite in NR2B. And it is interesting that NR1 is expressed in proliferative progenitors. And so the proliferative progenitors are the cells that are like the mother cells that can divide and then move towards the surface and migrate. So it is interesting that these receptors are also in the basis of the generation of brain tissue and also organization of this brain tissue. This is why we can find also cortical malformations later on, as we will see. But glutamate is not alone in the brain, but it has to work together with other neurotransmitter systems, dopaminergic pathways, GABAergic pathways we already mentioned, and other cholinergic, other systems. We still don't know exactly all these connections between the systems. Some of them we know, some others we don't know. And in particular, during development, there is a lot of work to do, still a lot of work in order to understand which is this combination or interaction between glutamatergic and other systems. And for sure, the expression of NMDA receptors probably should be modeled by the action of other neurotransmitters, not only glutamate. So what are the main messages of this very first part of my talk? NMDA receptors are ionotropic receptors, channels, glutamatergic receptors. Glutamatergic neurotransmission is excitatory and the most abundant in the brain. These receptors are widely distributed and regulated in time and space, not only at different stages of development, but also different areas of the brain. And these receptors are involved in very important functions of neurons. They are crucial functions of cognitive and behavioral functions. And this glutamatergic transmission should be integrated in the complexity of the brain as a system, and not only as a single molecule or as a single receptor. And this is a very complex task also to work in the future. So what about the symptoms? This is the second part of my talk. So we will move to the single neurotransmitter microcircuits to macrocircuits, and these macrocircuits and the connectivity of the brain will be more related to the symptoms that we found in patients. So as we already showed this slide in other talks, so what we find in GRIN-related disorders is a spectrum of severity and a spectrum of symptoms that go from the very severe encephalopathies that associate cortical malformation, severe epilepsy, all functions are disturbed, motor functions, the child can be chair-bound, and has a lot of problems of communication, severe intellectual disability, but other cases have only mild intellectual disability. In the middle, we have different kind of symptoms. Neuropsychiatric problems, behavioral problems, autism or autistic-like behavior is also quite common. Movement disorders can be also a problem, although, and according to my personal experience compared to other synaptopathies, because this spectrum we found in all kinds of synaptopathies, we call synaptopathies mutations that appears in proteins that are in the synaptic cleft, in this space, and even in the astrocytes too. And this is very common in all synaptopathies, but they express in a different manner depending on the gene that is a factor. And movement disorders are not really prominent in GRIN disorders, compared to other synaptic problems where they are major problems and very difficult to treat. So if we start from the first report by Dr. Endele 10 years ago, we found a group of important publications from that time until now that have provided important also data about clinical signs. And we know that there are probably more than 500 individuals with the GRIN variants reported. So we will try to go to the main features of every variant. We have here a summary of all of them, and then I will try to go to the details, in particular to those features that are probably more difficult for you to understand as patients. So GRIN1 is associated with mild profound developmental delay, severe intellectual disability, infantile onset seizures, oculogyric crisis, and bilateral polymicrogyria. This is probably one of the most severe associations that we found in GRIN-related disorders. So I will focus in, because all these aspects you probably know, but I will go to the most difficult ones in order to explain what it is. Well, I will go to oculogyric crisis and bilateral polymicrogyria. I will try to explain a little bit what is polymicrogyria. Polymicrogyria is a neuronal migration disorder. I just mentioned some slides ago that some receptors, GRIN and NMDA receptors in the prenatal life of the brain are based here in the ventricular zone where neuronal progenitors are. These neuronal progenitors are mothers, are cell mothers that will be divided and will form other cells and will migrate to the most external layers of the cortex. And if this migration, if this travel is not organized properly, we have a disorganization of the cortex. This cortex has an abnormal shape, and for sure, all the neurons that are here that are really important, GABAergic and glutamatergic neurons, don't work properly. So the control of cortical neuronal migration has very different molecular actors, but glutamine and GABA are important. And it occurs very early in life, between 12 and 20 weeks of prenatal life. So in GRIN1, we can find this polymicrogyria in the surface of cerebral hemispheres. And these are multiple small bumps, as you can see here, suggesting an excessive number of gyri. There are too many gyri, but they are not well organized. They are irregular, overfold, like festooned. And this polymicrogyria can be diffused, so all the brain can be affected, like in this picture, or only some areas are affected. These areas are really epileptogenic, very, very epileptogenic. An important proportion are perisylvian. These are perisylvian areas, the one that I am showing here with the arrow. This has been reported in GRIN1 that bilateral extensive polymicrogyria can be one of the features, as you can see here in the brain MRIs. And these children with this extensive polymicrogyria in general have global neurological involvement, severe problems of development, and also severe problems of seizures. So probably these are the most severe phenotypes. Oculogyric crisis, but for sure, not all patients with GRIN1 have this kind of abnormalities. Some patients may have that, but not all of them. And all of them may have also less severe forms, for sure. So this is also very common only in this subgroup of NMDA receptor mutations, and it's the oculogyric crisis. And I will show you what it is. Oculogyric crises are abnormal movement of the eyes, as you can see here in this video. That is a video that is a public access video. Look at this child with this sustained conjugate upwards deviation of the eyes. This can last seconds, but sometimes hours. In particular, it can last hours in this disease. This is not a GRIN-pathy, this is an AA deficiency, it's another kind of neurotransmitter disease. and it reflects, in fact, a dopaminergic pathway disruption. There are many other disorders that can have this clinical sign, but not many, but some of them, and we as child neurologists know these disorders. But in fact, in patients with GRIN1 can have this abnormal eye movements, and in my short experience seeing these patients compared to other causes of eye deviation, as you can see here, these eye deviations are really slow, and in general they tend to be in this disease to the same direction all the time. It's like very stereotyped, but the children that I see with GRIN and these abnormal movements of the eyes are really fast and go in all directions. But this is a single observation, and maybe it is not a generality. That's why deep phenotyping is very important in order to characterize different diseases from a clinical point of view, and also to establish some kind of prognosis and for sure for treatments. In GRIN2A, normal or near normal development with mild epilepsy, speech delay, apraxia, to severe epileptic encephalopathy with epilepsy aphasia spectrum has been described. There is a recent very nice paper by the group of Dr. Lemke that explains a little bit all these signs and tries to correlate with some particular variants, those that are in transmembrane and linker domain, have severe developmental phenotypes. Also those gain of function mutations have a more severe phenotype. GRIN2B. GRIN2B should be considered in cases with mild to profound developmental delay, intellectual disability, epilepsy, behavioral problems such as autistic-like behaviors, hypotonia, movement disorders, and sometimes also cortical malformations and cortical visual impairment. And this could be a cartoon of all things that we can find in GRIN2B, developmental delay, which is or intellectual disability, which is almost constant in different degrees. Epilepsy, half of the patients can have epilepsy, autistic features, almost 30%. Motor signs are sometimes present. Hypotonia is an important motor sign, but then hyperkinetic movements and other are not that common as in other synaptopathies, as I already mentioned. And in some cases, brain cortical malformations are also present, as we can see here in these brain MRIs with these severe abnormalities, also polymicrogyria and some other cortical malformations that can be really very, very important. But most of them have normal or just very subtle changes in the MRI. And some of these children have what we call a cortical visual impairment. That means that the eyes work properly, but because all the transmission from to the cortex, I mean, in fact, we see with the brain, we need the eyes, but the interpretation of the images takes place here in the occipital lobe. So if the occipital lobe has some kind of micro abnormalities in terms of cortical organization, we can have this cortical visual impairment. So the child doesn't direct properly the eyes to an object, doesn't follow properly. We can have also other causes. This is not the only one for sure, but sometimes this is the cortical visual impairment that produces this visual abnormality in children. Epilepsy is diverse. Generalized seizures are the most common, but then focal and epileptic spasms are also something common. Focal seizures is these seizures that are generated in a particular area of the brain, and in the EEG they give spikes only in a particular area, whereas generalized crises are an activation of the whole areas of the brain at the same time, and the general discharges are seen in the EEG. In a study follow-up in 22 patients, 50% become seizure-free over time. So sometimes this is something that appears in a particular moment, but then this epilepsy just improves and this even disappears. GRIN-2B can also produce a Landau-Kleffner disorder that is also found in other subtypes of GRIN-related pathologies. And this Landau-Kleffner syndrome is what we call the epilepsy aphasia syndrome, and is a language regression of children of between 3 to 5 years of age. And this language regression is associated with seizures, with abnormalities in the EEG, and behavioral abnormalities. Then we have other kind of seizures. We are not going into the details. And in this recent paper of the group of Xavi Altafaj, they try to just differentiate some of these clinical aspects. If we compare GRIN-2A with GRIN-2B, we see that epilepsy seems to be more common here. GRIN-2A, this is a short series of patients, but well, more or less it can be representative. Speech disorders are also more common in GRIN-2A. Autistic features are more common in GRIN-2B. So in spite of having a spectrum of clinical manifestations that are common, we can find some differences. And GRIN-2D, we had little information of this variant, but this group of disorders. But during this year, we have had a couple of interesting papers, and this is one paper in Brain that tried to illustrate, not in Brain, is the other one that is not in Brain, and this is the other also important paper, trying to illustrate a little bit what kind of symptoms these children have. You can see here epilepsy types that is also diverse, from hypsarrhythmia, which is a very severe EEG abnormality, sometimes related to a spasm, is a type of epilepsy, to multifocal discharges. And then you see here also cortical atrophy, so abnormal brain MRI abnormalities, autistic features, hypotonia in 9 patients, and refractory to anti-epileptic disorders, the epilepsy in also 9 over 12 patients. So we need for sure more characterization. So this is again like the message of this clinical description is, okay, we have a spectrum, but we have seen that some particular subgroups of disorders have some specific signs. And so this is why it is very important to have a very clinical information of high quality in order to better characterize and to have a nice information, not only about the presentation, but about the natural history, the outcome, the evolution over time of these patients. And I move to the third part and the last part of my talk, which are the treatments. And as has been already mentioned, we try to organize the treatments according to the mutations. If the mutations are a gain of function, we try to have an approach. If the mutations are a loss of function, the approach is different. So we'll start with the loss of function mutations. In these loss of functions, it is, well, like logical that if we give some kind of molecules that stimulate the receptor that is not working properly, these molecules will probably have an effect to potentiate, to stimulate the function, because the receptor is moving very slowly, is going like, it's like a receptor that is tired, and you need something to stimulate, to push the receptor. So what can we do in this loss of function mutation? So we can make the receptor work better through agonist binding. We can increase the expression of the receptor, or we can use other mechanisms. These are some options. There are probably more than these options, but this is just to summarize some of the options that we can do already, and we are already doing. So there are substances, molecules that make the receptor work better are L-serine, that will be metabolized to this serine. Dr. Natalia Julià will tell you about the clinical trial that we are currently, so it's currently going on. Other molecules that are in development, also in Dr. Altafaj's lab, and positive allosteric modulators. We can increase the expression of the receptor, and maybe piracetam is able to do that, and maybe because we have poor data supporting this, few data supporting this hypothesis, or other mechanisms like the ketogenic diet. So I will just say a word about L-serine because my colleague will talk a lot about it. So L-serine, what that we give with the diet and as a supplement, is converted to D-serine in the brain by an enzyme that is called racemase. And this D-serine is a neurotransmitter that binds to the NMDA mutation receptor and promotes the stimulation and makes this receptor works better. It is in fact a glial transmitter because it is not synthesized in neurons but in glia cells that surround the synapses. And interestingly, glutamatergic neurons are the primary site of the serine synthesis. So this is very interesting and makes more sense in order to give L-serine to these patients. This comes from a paper that explains that D-serine can be useful in the management of anxiety disorders, but now D-serine, we know that it can have many clinical applications, only as a cognitive enhancer in depression, for sleep disorders, and for metabolic diseases. I mean, I think we should, in fact, write a review about all the potential utilities of L-serine converted into D-serine to improve neurological conditions. What about piracetam? We mentioned that it can stimulate, it can increase the function of NMDA receptor also. Piracetam is a nootropic, which is a cognitive enhancer. It was synthesized a long time ago, and it has many other functions, not only involving NMDA receptors, but it stimulates also other neurotransmitter systems, the dopaminergic, noradrenergic, cholinergic. And apparently the action that is interesting for NMDA is that it increases the number of contacts between the receptor and the agonist. So it will increase the number of contacts between glutamate, for instance, and the NMDA. So it will improve the function of NMDA. This is the theory. There are very, very few studies in this direction. So far has been done. We give, in fact, not piracetam in neuropediatrics for myoclonias. There are non-cortical myoclonus. There is a kind of movement disorders, and it works very nicely for that, or at least works. So the indications so far beyond these myoclonus are cognitive decline in Alzheimer's disease, and also the reversion of cognitive impairment that is seen in patients who are for long periods in intensive care unit, and also students when they are in exams, they have tests, they are stressed, they have a lot of things, and they have to be very performance. They take it to increase attention, concentration, and academic performance. What about ketogenic diet? This is interesting, and this is something that we are using more and more in our neuropediatric practice, not only in GRIN-pathies, but many other diseases. So it seems, and it has been demonstrated in theoretical models, in animal models, that when NMDA receptors are dysfunctional and NMDA are expressed in neurons, but are expressed also in a cell that is a glia cell, the oligodendrocyte. The oligodendrocyte is a cell of the nervous system that is responsible for the production of myelin that surrounds nerves and improves and facilitates nerve conduction. So these NMDA receptors, when they are not working properly, they don't work properly in all cells of the brain and also in oligodendrocytes. So when they are working in a normal way, it has been found that the transporters of glucose that take glucose from the systemic circulation from what we eat and for our diet and bring it to the astrocyte and convert that in lactate for the neurons and so on. So these transporters of glucose are decreased. So we have less glucose in our brain. Theoretically, if we have NMDA receptor mutations. In particular, it's, I suppose, but this is just something that has not been demonstrated in loss of function. This should be more important, but I really don't know if this is true. We have found some in some of our patients with GRIN-pathies, and we are conducting a study of the CSF study, the lumbar puncture, to analyze the CSF and different molecules. We have found in some of them low values of glucose. So this can be a little bit true, according to this explanation. So ketogenic diet is the main goal is to produce ketone bodies. So the diet has been mostly composed by fat. 90% of the total calories have been composed by fat. And then the relations between fat, proteins, and carbohydrates can vary according to every patient or every disease. And it is very important. It has been should be controlled by health professionals. You cannot do that as a patient alone, because it has complications if you do that by your own. It has to be controlled and monitored with different parameters. The main indication so far is refractory epilepsy, but we are using a ketogenic diet as a neuroprotector more and more, and in particular in very young children, in order to change the natural history of diseases, because this ketogenic diet improves many energetic functions of the brain. Ketones, glucose is a molecule that is important as an energy molecule for the brain, but ketones are the second one and lactate the third one. So these three molecules can be used to obtain energy, and the energy in molecular terms is ATP, is this molecule. So in ketogenic diet we have more ATP, but then we have more GABA function, so we have a little bit and a stabilization of the synaptic function, so that can improve epilepsy, but it can improve also other cognitive and behavioral problems. And what about all these mutations that produce a gain of function? So we can block the receptors and use some antagonists. We can decrease glutamate release using a conventional anti-epileptic drug, or we can even increase the reuptake of glutamate in order to decrease the quantity of glutamate as an agonist. We will explain a little bit that here later on. So we can, okay, so this is, we can in fact try to decrease the amount of glutamate. If we have an hyper-excitability in the NMDA and the excitatory molecule is glutamate, maybe we can decrease release of glutamate. And lamotrigine is one of anti-epileptic drug that can do that. But this is just a theory, an idea that comes from the theory. This is has not been proved. We have some blockers that have been proved, like memantine, ketamine. There is a publication of radiprodiol, we will see, and another option will be dextromethorphan too, that can block NMDA receptors as antagonists, not agonists, but antagonists. They block the function. And then some antibiotics, such as amoxicillin clavulanic, increase the expression of this transporter, which is the excitatory transporter of the glial cells. So they remove glutamate from the synaptic cleft in order to decrease the quantity of glutamate. So if we have less glutamate, we will have less activation in this receptor that is already overactivated. But this is just an idea, and it has not been proved. It has been proved in other conditions. This is a very recent publication showing the effect in vitro of the different kind of drugs that have been proved to block NMDA receptors. It has been proved in particular in GRIN2D, and well, they have a similar effect, in fact. And this is the publication of with radiprodiol, that is an NR2B negative allosteric modulator to treat, and it has been proved to treat patients with infantile spasm. And that after some months, 11 months, 10 months of follow-up, they remain spasm-free. So it can have maybe, it is an option maybe in the future for these patients. And well, just a comment here. So is this loss gain of function approach useful to design personalized therapies? We think that yes, for sure, and it works in some patients, also in other neurodevelopmental diseases. For instance, in this channelopathy, KCNQ2, there is carbamazepine, which is an anti-epileptic, can totally restore some of a specific mutation. So we strongly believe in this approach, but it has limitations because it may be too simplistic, because the activation and inhibition of glutamatergic neurotransmission has multiple regulators, and we know little about these mutations in terms of the whole function of the brain as a system, how other secretaries are affected, what other biochemical markers could behave in this excitatory inhibitory balance. So there is also a temporal window with some particular ages where moments during development where these treatments can work and then stop working as the child grow up. So in fact, there is a complex network of glutamatergic GABAergic circuits that, glutamatergic are much more abundant than GABAergic. So, and even if a glutamatergic neuron is going down in function, the global excitatory transmission compared to with inhibitory is higher. So we don't know exactly the final balance in the brain, even in the loss of function mutations, how does it work? And I will finally mention this. This is another totally different approach. It is a recent paper also about immunotherapy in these diseases. So immunotherapy consists of giving immunoglobulins. It is given normally when there is a problem of immunity, autoimmune problems. So the body produces antibodies, so substances that block a receptor and impairs function of neurons or other organs. So here, these immunoglobulins try to remove these antibodies in order to have a better function, and this has been proved in 5 children with different diseases: GRIN2A, GRIN2A, GRIN2D also. And what they found is an improvement of the EEG and also some mild response in some other cognitive and global functions, but also at the clinical level in terms of epilepsy, because it has been described for a long time ago that there is a relationship between epilepsy, inflammation, and these immunomediated mechanisms. And maybe here that this is a single paper, but this is something that also have a role in the treatment of GRIN-related disorders. So to conclude, these disorders are a group of young disorders because it is 10 years from the first description. So we know already a lot, because 10 years is a very short period of time, but we still have a lot to learn in the future. It is important to develop precise and detailed characterization from a clinical, molecular point of view, also research models, and these will help to define the therapies. And probably this is the most important message. We need a collaborative network of clinicians, researchers, patients in order to work together, because the only way to face complex problems is working together. Collaboration is one of the main important aspects in human evolution that has contributed to the major improvements of humanity. So that's all. I'm sorry, maybe I have been too long. the exposition has been too long. This is our group, but for sure the Barcelona Green team is the major contributor of everything. So, well, thank you very much. Sorry for the time.
Thank you very much, Angels. We don't have a lot of time, so we're just going to give the next to our next presentation. Natalia will be presenting about the L-serine trial. We'll take the questions at the end of this block. Hopefully, we'll not go over. So I leave it to Natalia to continue. Thank you.
Thank you, Sandra. Thanks, Sandra. Do you hear me? Yes. Good afternoon, everyone, and welcome to my presentation. I'd like, first of all, to thank the organizers of this meeting for giving me the opportunity to share with you our SERIN clinical trial. I'll divide my talk between two main parts. I'll begin by giving you a brief overview about the L-serine. Then I'll explain how L-serine works at NMDA receptor and the way that serine could help our children with GRIN-pathies. And in the second part of my talk, I'll introduce our serine clinical trial. Well, to start, serine is an amino acid. An amino acid is a building block for protein. And serine comes in two forms. The first one is L-serine, and the second one is the D-serine. L-serine can be consumed by the diet, and also it can be made in our body, while this serine can only be made in brain by serine racemase from the L-serine, and is the D-serine that acts as an agonist in the NMDA receptors. L-serine is distributed in the aliments, for example, in soy products, in eggs, in meats, sweet potato, and is the form that it could be found as a dietary supplement. Indeed, L-serine is considered as GRAS, generally recognized as safe by the FDA, and has been approved as a normal food additive. Serine is needed for multiple functions in the body. It's needed for the metabolism of fats, fatty acids, cell membranes, cellular proliferation, for healthy immune system, and as a neuromodulator. About indications of serine, L-serine dietary supplement has been used for many years in pediatrics at dose of 400 to 600 milligrams per kilo day for the treatment of serine biosynthesis and transport defects with no reported adverse events. And the last years, serine received renewed attention as a potential therapy for schizophrenia, depression, Alzheimer's disease, ALS. It also works as a human sleep inductor, and moreover, serine has been used as a procognitive, works as with procognitive effects in healthy individuals. But how does L-serine work at NMDA receptor? And especially serine, what can serine do for our patients with GRIN-pathies? Well, I try to explain with the following graphic. Here you can see the NMDA receptor. The NMDA receptor are one of the main important excitatory neurotransmitter. NMDA receptors, NMDA receptors are receptors mostly composed by 4 subunits. 2 D-serine glycine binding GLU-N1 subunits encoded by GRIN1 gene, and 2 glutamate binding GLU-N2A and GLU-N2B subunits encoded by GRIN2A and GRIN2B gene specifically. Therefore, the existence of GRIN gene variants can disturb the function of the NMDA receptors, and this dysfunction may lead either of a gain of function or a loss of function of the same. That's, in other words, That's why this serine can help our patients with loss of function variants activating this receptor. So once your child neurologist determine that your child is carrier of a GRIN gene variant, it is important to define two things. The first is define if it's a real pathogenic variant disease causing, and the second is to determine the functionality of the receptor and its annotation. If the receptor acts like a loss of function or with a gain of function of the receptor. So please remember that serine acts mainly in patients with loss of function variants. And in a proof of concept, our group have determined that a GRIN2B variant with a loss of function can be rescued by L-serine supplementation. And according to this finding, they have recently described the beneficial effect of chronic L-serine dietary supplement in a GRIN, in a 5-year GRIN2B girl. And she showed an improvement in both motor skills and in psychological function. Well, in this second part of my talk, I will explain about our serine clinical trial. And let me only this slide to explain to you why it is important, why clinical trials are important steps for discovering new treatments. I'll give 5 reasons. The first one, and one of the most important, that why we are conduct a clinical trial, is because the results can affect many more patients. If I conduct a clinical trial and ultimately bring a new treatment, we can potentially impact thousands of lives. Second, they bring new treatment to market. Without a clinical trial, participants' advances won't happen. Third, they provide good information. If we conducted a clinical trial, we can systematically test to determine which drug is more effective. 4, we want to make sure that a new treatment is safe and effective before it is brought to market and in clinical practice. And finally, they take out a physician's bias. Well, and finally, the most important part of my talk, I would like to share our serine clinical trial protocol for patients with GRIN-related disorders caused by the presence of GRIN variants leading to a loss of function of the NMDA-receptor. After our single experience with the girl that I have talked earlier, we want to translate this unique experience in a bigger group of children with GRIN pathies. So we wrote a project, and we applied with this project to a nutrition metabolics research fund, and we award a grant. And thanks to this grant, we will be able to conduct this clinical trial. But it's important to remark that this is not a clinical trial from a pharmaceutical industry. This is a trial that we will be able to carry out with the grant that we obtained with this fund. So our budget is limited. So we will not be able to recruit patients outside from Spain. We will start with recruitment patients from our country. But please don't be sad about that, because let me invite to your child neurologist contacting me, because I would be really happy to share with them our protocol. it will be really nice to homogenize the assessment for each patient who takes serine. Well, about the trial, we hypothesize that independently of the molecular etiology, NMDA receptors activity potentiation throughout L-serine dietary supplement can ameliorate glutamatergic function and improve the life quality of children suffering from GRIN-related disorders. And our second hypothesis is that the dietary supplement of L-serine results on increased D-serine plasma levels and potentiates NMDA receptors, leading to NMDA receptors functionality increase and hypofunctionality rescue, as shown in the pilot study. Sorry, I have put, sorry. Okay, sorry. The purpose of this study is to determine L-serine dietary supplement efficacy for the treatment of patients with GRIN-related disorders caused by the presence of GRIN genetic variants leading to hypofunctional NMDA receptors. We have two primary objectives. The first one is to know the dose tolerability based on subject interviews and schedule assessment, evaluating the presence or not of adverse events. And the second objective is to know the efficacy based on neuropsychological and motor assessment. Such a secondary objective, we want to study the effect of L-serine in microbiota composition, and for that purpose, feces from patients will be collected. About inclusion criteria for participate are to be a girl or a boy between 2 and 18 years inclusive, who live in Spain, patients who have a confirmed pathogenic GRIN gene mutation with a diagnosis of encefalopathie associated with genetic GRIN variant pathogenic or likely pathogenic causing a loss of function. And like another clinical trials, it's essential that parents or legal representative give written informed consent for participation in the trial. And finally, that the patients and caregiver are willing and able to comply with all trial requirements. About exclusion criteria for participate, don't have a diagnosis of encephalopathy with a GRIN variant pathogenic or likely pathogenic causing a loss of function, patients who are currently using or have used within the 30 days prior to screening L-serine supplement, and finally, patients that have been previously randomized into this trial. About study timelines, our first patient screened was in July, and the target last patient enrolled will be in January 2021, but it is possible that cause of coronavirus crisis, we extend the target dates. The enrollment target are 20 subjects who live in Spain, and we are really happy to announce that we already have 5 patients underway, and 2 patients of them have already started treatment with L-serine. But of course, this is very soon to give more information about the results. They are only have maybe 1 month with L-serine treatment. About study design, it's a phase 2A study with a single group assignment. The study has a duration of 15 months. All children will receive L-serine over 12 months. During the study, 6 visits will be done, and the examinations will be performed at 3 months and 1 day before starting the treatment, and 1 month, 3 months, 6 months, and 12 months after the beginning of the L-serine. About doses, a total daily dose of 250 milligrams per kilo day of L-serine will be given from week 0 to week 2, and from week 3 to week 52, 500 milligram per kilo day of serine have to be given. Here I present the template of the assessments by visit, where you can find the different neuropsychological, motor, and sleep assessment. As well, we will evaluate the epilepsy with a subject epilepsy diary and with the performance of a EEG evaluation. Here you can in this table you can have the frequency of the assessments. Well, about L-serine, only some words. L-serine will be manufactured, packaged, labeled, and distributed by Nutricia or delegate contractors. It will be present in a powder form of 100 grams of the amino acid. The volume is determined by patient's weight, and the dose is the following that I have earlier mentioned: 250 milligram per kilo day during the first 2 weeks, and then from week 3 to the week 52, 500 milligram per kilo day. And to end, we must take under consideration some possible adverse events that have been reported in the literature in another kind of diseases. Mostly are mild to moderate events, and they can include abdominal pain, nausea, dyspepsia, loss of appetite, vomiting, constipation, and less frequent nystagmus, acoustic startles, or myoclonus. Of course, all of them are reversible, stopping the serine. Well, before I finish, let me thank to the Barcelona GRIN team, because without their previous and current research, this trial couldn't be possible. Of course, here in this slide, there are many collaborators that miss it. And of course, I would like to thank all the clinicians that contacting us every day, giving information about their patients or genetic study or the clinical phenotype. And I don't want to forget thank the parents and our patients, because for placing their trust on us every day. And that's all. Thank you for your attention. I'll be happy to answer any questions you may have. Thanks.
Thank you very much, Natalia. Thank you very much, Natalia. We have a few questions, so we'll try to go as fast as we can before the lunch break. And please, I want to remind everybody if they can fill out the Survey Monkey, which is linked in the chat. I'm going to go in order with the questions here in the Q&A, and I have a few more they've been sending. So we have this first question. My daughter has a nonsense mutation, but a profound and multiple disabilities across board: speech, cognitive, physical. So by Xavi's logic, could she also have another mutation?
No, necessarily. I mean, there is, even in the same mutation, there is a spectrum of manifestations. So it could be the only cause. Yeah, why not? Yes. We see I mean, two patients with absolutely the same mutations can behave in a different way, in a very different way or a mildly different way. It depends on every patient. Yeah.
We have another question. My daughter is 11 and has never had epilepsy. Is she likely to develop epilepsy later in life?
Oh, we don't know. It is not possible to know that. In fact, if the epilepsy has not appeared during the first stages of development, it is something of a good prognosis, because the most severe epilepsies tend to appear early in life. So it is something very positive, but it is impossible to know if later on she could develop epilepsy. But in any case, it doesn't look like if she develops epilepsy, it doesn't look like this epilepsy will be severe. Maybe she could have one seizure or a couple of seizures and then be treated without any problems. But this is not possible to be answered. We just don't know.
I have another quick question. This is, can GRIN disorder be discovered during pregnancy?
Because of the fetal abnormalities that that's a very interesting question. If let's figure out that there is a problem at a brain MRI. Well, see, a MRI of the fetus and a brain MRI of the fetus is performed, and a polymicrogyria or something similar is affected, and then a very quick genetic test is performed and directed to these genes that can produce these brain malformations. Maybe yes. But this is not something that is in the standard tests that during pregnancy are done to detect abnormalities like Down syndrome or other kind of chromosomal abnormalities that are now tested.
Thank you. Our son is a loss of function, but recently he's been put on lamotrigine for epilepsy, which only started in the recent years, and he's already 28 years old. Based on what you said, and given the fact that you can use it for gain of function, could this be detrimental for him?
No, I don't think so. I don't think so, because, well, it has also other functions. So no, not specifically. I don't think so. No, it depends also on every patient. If the response that has been positive and seizures have improved, it also depends on the age. I mean, the anti-epileptics that we use are also based on the type of epilepsy and on the age of the patient. So yeah. Mm-hmm. And in this case, lamotrigine will be used not only for epilepsy, but as a treatment in general, no, as a modulator in general of glutamatergic function in gain of function. Mm-hmm.
Okay, but even though if it's a loss of function, would gain of function be? I mean, the way it works would not affect the loss of function too.
If you only want to, if you want to normalize the epilepsy, lamotrigine has other functions, not only this decrease in the release of glutamate. So I don't think the epilepsy is solved and controlled, even if it has a loss of function. I don't think that it should be detrimental, because it is not the quantity of glutamate that will be removed from or will be decreased using this drug probably will not affect the whole balance of having an epilepsy, you know. So, well, it's a question of a multifactorial approach. Mm-hmm.
Thank you. With a nonsense loss of function, would something that makes the receptor work better through an agonist binding be worthwhile? And if there's less receptor, then presumably something like L-serine wouldn't be appropriate, as it cannot work on the receptor?
Mm-hmm. I don't understand too much this question. What is the exact meaning?
No. I think what it refers to is that if you have a loss of function and you have already a truncation in this case, adding serine is not going to improve, because you actually don't have as many receptors in the surface as you would if you would just add the serine, and you would improve the
Yeah, so if we could add something different, or just L-serine won't work at all. Yeah, it is true that some of these patients, in our experience that we have had, L-serine works just maybe for a very short period of time, and then it doesn't work anymore, or it makes a very, very poor effect. Yeah, probably other kind of agonies or other approaches are needed. I mean, I think, yeah, you have to personalize every kind of in every patient, what do you choose as treatment? Mm-hmm.
If I can expand a little bit, follow-up of these questions, because we are currently investigating the effect of L-serine on GRIN truncations, and indeed it is working on this small pool of receptors that are still remaining in that they are normal. So there is a decrease on the density of these receptors, but at least they can respond, and those that are functional, they respond to L-serine, and we are trying to adapt the dose of L-serine. So these are the experiments that Anna is conducting, and also to identify new compounds that can have even a higher potentiation of the loss of function variants, not only truncations, but also the others. So yes, the answer is that L-serine can be acting, but exclusively on those receptors that are functioning with no truncations.
Just following a couple of serine questions or questions in general, do you see an age issue when treating? I know that you stopped the recruitment for the serine at 18, but could the serine or any of these medications help patients beyond that? So, there's some mother has a child who's older, over 20, and they wondering if there's anything that could work, or they would still see a difference. Is there any treatment for these children?
Yes, but it can be useful not only for children patients. That's because our hospital is a child hospital, so we will start with patients between 2 and 18 years. But if we have good results, of course, we can use in more patients. Yes.
I have a question about the serine trial. There's a family in Madrid that's been waiting for the ethical committee to go through, and this is just a question about how it works. If you can get an ethical committee across a country, or you need to get it hospital by hospital, and if you have anything to comment about that. And this, I think, goes to the future of trying to get the GRIN community and the doctors working together with us in the hospitals everywhere for future clinical trials too.
Yes, we know that that's a big problem. In the beginning, when we create the study, the study design was something different. Our first aim was that every patient can come to our hospital, and that's all. But after, because of the coronavirus crisis, things changed. And with the collaboration of the clinicians from the different cities from Spain, we will be able to carry out the study. But the problem is that each of the ethical committee has to approve in some cases has to approve the protocol. And in case of Madrid, I know that the Dr. Soto has a lot of problem about that, and we are waiting for the answer of their committee. Yes, it's not a good are not good news, but it's the only way that we have now to act. Yes.
The other question is the families have read the use of, when prolonged use of L-serine, the use of folinic acid.
Mm-hmm. Well, this is because L-serine metabolism and folate metabolism are connected. So if we stimulate the pathway of L-serine, we can finally, use a lot of folate, because folate is needed for methylation reactions all over the brain, and this can lead us to a secondary depletion of folate. That's why this is something that we do in L-serine deficiency synthesis diseases, in metabolic diseases, that we learn that from these disorders, and that's why patients with L-serine treatments for long periods are recommended to be supplemented with folinic acid.
Thank you. I have another question, because you mentioned piracetam, and there's a family wondering if you can use the piracetam with the L-serine.
Yeah, sure. It makes sense. It makes sense because what you are doing, but theoretically, what you're doing is to improve the binding of agonists to NMDA receptors. So you will improve glutamate, but also the serine in that case. So yes, why not? It is, yeah, you can use like multiple treatments if they are safe, for sure, that goes towards the same goal. So yes, sure, yeah.
We have another.
Yes, about the EEG in the clinical trial.
Yes.
Yes, we are not expecting to find something special, but as we know, some patients with GRIN-related disorders have epilepsy, so we will take care of all of the possible effects that they will have or not with the L-serine. It's only to be sure that, for example, one patient with epilepsy works with the L-serine treatment, or the EEG works, but we don't expect something special.
We have another comment here about the serine. So I'm going to try to pull all the serine questions, and then we need to break, and we can continue on the roundtable discussion, especially the more general ones. The serine, could we saturate the brain with too much L-serine?
Saturate? Well, in another kind of diseases, for example, in ELS or neuropathy, they are used, I think, 30 grams of serine without any adverse events. So
yeah, the doses the doses that we are using are safe doses, because they have been used in other diseases for decades, for many years, and no adverse effects have been reported. So for sure, if you give tons of serine, maybe you have a problem, but we try to use doses that are the recommended and safe doses.
Safe doses, yes.
I think maybe what we need to would like to hear from you is also because a lot of families want to try serine, but I think the way to try serine is through their doctor, and ideally through the doctor, contact you guys and take advice from them, and not have families just run to the first, Amazon.com or whatever and start trying it. So because there's a comment here that their family is trying. How can you check for the difference? I think the best way is to have your doctor prescribe it and do the appropriate tests in order to even see if there's something going on. There's a mouse question here, and I'll leave that when Amy joins the call at the end of the round table, because I don't think, at least she is one of the people doing the mouse, and we don't still know of anything about the L-serine trial in mice. So with the past experiences from L-serine, did you see any improvement in the IQ or any other ways of any improvement did you see with L-serine in the past? before the study, of course. Or if you've seen anything with the study, I think it's too early, maybe.
Well, in some patients that we treat before that are not included in the trial and have been treated, they report some benefits, and for instance, well, in attention, in well, the interest in their surroundings and the social interaction, also in particular in mild cases, those cases with mild in developmental delay or mild intellectual disability, they are also able to talk a little bit more, to communicate more, to understand. So, but we have not evaluated that, or still evaluated with objective standardized tests. So we have to use IQ tests or developmental tests or behavioral tests. So these tests that are recommended to have a validated information, because only the information that parents give sometimes is a little bit subjective. So, but we will do that. And apparently, yes, but not all the functions improve in the same way. And this is something that we have to study with the clinical trial. We will have this data.
Yes, in some patients also the sleep improve,
yes,
for example, but as Angel said, that's why it's necessary the clinical trial to evaluate in a bigger group of patients the different neuropsychological assessment or motor sleep assessment.
There is one non-English German, a German question as well there. Does the severity of epilepsy change during puberty or with onset of puberty?
I don't know. I mean, this is true that there are some, in general, that there are some developmental periods where the possibility of epilepsy impairment increases, like, well, at the beginning, during the neonatal period or the first year of life, the brain is very active, so the activity is very high, so there is a lot of excitability. So here the brain is very vulnerable to epilepsy. Puberty and adolescence is also a period of vulnerability, and then the very old person, so the ancient person also. So these are the periods of life where there is more probability. But I don't know exactly in the case of GRIN disorders. I don't have personal experience. In some series, it has been described that more or less half of the patients can stop the epilepsy that they have previously had, but I don't know. I don't have a personal experience to answer this question.
For example,
Natalia?
in series of patients with GRIN2A mutation, that's more common to have a Landau-Kleffner or a specific type of epilepsy related to GRIN2A mutations during the childhood, for example, than when the patient is an adolescent, for example. No, so I think that yes, but it's what a series of patients describe.
Yeah, I think we have to look at every patient in a personalized manner and see, well, what is the kind of epilepsy that this patient have, or what has been the response to treatments in the past. So just to have a better idea to have a prognosis. But yeah, in a general way, I don't know.